bleeding and fistula formation with a pure laparoscopic approach. This is data compiled from high volume centers that have performed both open and pure laparoscopic partial nephrectomy, showing that lap technique can emulate the open technique with comparable cancer control rates and renal function on follow-up. But taking a look at the data in closer detail shows that it is associated with almost 10 minutes of higher warm ischemia time, less operative time, less blood loss, and shorter length of stay in the hospital. However, this is in the setting of higher morbidity with twice the number of subsequent procedures to treat complications, and again, what I should mention is a longer ischemia time on average of 10 minutes. This table shows my own robotic experience and compares it with outcomes of open and laparoscopic partial nephrectomy from well-established series that I showed in the previous slide. I think this highlights the role of robotics in bridging the gap between the pure laparoscopic and open approach, allowing for a almost 6-minute faster warm ischemia time in both simple and complex tumors, with the advantages of maintaining a decreased blood loss and a shorter hospitalization stay as compared to the open approach. And with time, I bet if we revisit the use of nephron-sparing surgery, both in this country and throughout the world, we will see an appropriate rise in the use of partial nephrectomy for small tumors that will most likely coincide with the adoption of robotics in a lot of practices. These are some key issues which I would like to highlight for nephron-sparing surgery when performed either laparoscopic or robotic. I do like to use a ureteral catheter when entry into the collecting system is a possibility to be able to identify it and close it at that setting. With regards to vascular control, a warm ischemia time should be kept under 30 minutes and preferably under 22 minutes. And I like to use bulldog clamps, 2 bulldog clamps with the newer Aesculap removers as opposed to the Statinsky clamp or the actual bulldog placer. And lastly, I think we have tools to help proper identification of the tumor intraoperatively with laparoscopic ultrasound probes, and would therefore highly recommend its use to avoid getting a positive surgical margin during the case. This is a typical port configuration for a 3-arm robotic approach. The yellow port is a camera port, the 2 orange circles are the robotic arms, and the blue circle is a assistant port and a left-sided robotic partial nephrectomy bisecting the right side of robotic arm and the camera port. This is a 4-arm approach, adding an additional arm for help with either placing bulldogs or mobilization of the kidney, and subsequently I do bring my assistant port down to the belly button, bisecting the camera port and the additional 4th arm of the robot. So, although I did not cover ablation in detail, given the time constraints of this lecture, I think the greatest drawback for tissue ablation is that intermediate and long-term oncological outcomes remain unproven. This is a nice multivariate analysis that has come out of the Fox Chase group, showing that the average age of patients undergoing ablation or surveillance is typically higher, and smaller lesions were more likely to undergo ablation, yet follow-up was longest for patients undergoing surgical excision. In this multivariate model, analyzing local recurrence rates and metastatic disease, this showed a risk of local recurrence as opposed to nephron-sparing surgery of 7 times higher with cryoablation and 18 times higher with radiofrequency ablation. So I certainly think what we now have to offer with fluorescence, robotically assisted laparoscopic partial nephrectomy, will soon become the new gold standard approach for the treatment of small renal masses. And what is fluorescence? Fluorescence imaging is a system to allow for advanced imaging of perfusion and real-time intraoperative detailed and confident visualization of critical anatomy. This picture taken with a white light telescope shows the renal hilum. This is the same exact picture taken with a near-infrared fluorescence image showing that the renal vessels, specifically the renal artery, has been injected with a dye and is fluorescing green at the same exact setting. Fluorescence imaging allows for solid tumor identifications. Certainly tumors that may not be clearly visible in standard white light mode. Again, a exophytic renal tumor being visualized in white light mode, while seen in fluorescence, you can see that the normal parenchyma fluoresces bright green as compared to the dull gray appearance of the tumor itself. Just briefly, following intravenous injection, indocyanine green is rapidly bound to plasma proteins, of which albumin is the principal carrier, about 95% of it, and it's rapidly uptaken by blood vessels and then goes into the systemic circulation to allow perfusion through the kidney, followed by exclusive uptake by the hepatic parenchyma cells and then subsequently secreted entirely into the bile. The 2 to 5 minute half-life allows for multiple applications and injections in a single agent. And so fluorescence applications for partial nephrectomy, it allows parenchymal reperfusion, it allows for confident visualization of the hilar anatomy. These are 2 renal arteries which was dissected out and confirmed to be the only supplying vessels to this kidney. It also allows for hilar dissection in patients who may have a lot of perihilar fat, clearly identifying any accessory arteries that may be present. It assesses parenchymal perfusion during tumor excision, so you can potentially use it to guide your margin status during the partial nephrectomy. I'm putting potential applications in quotes in this slide because from an FDA clearance standpoint, this was not part of the FDA application, but we do have an IRB protocol underway to study this in addition to an ideal dosing regimen. 1, to help identify tumor extent in real time to guide extension. This is a heminephrectomy of a very large central tumor in a patient with a solitary kidney, showing this lesion that looks like perihilar fat. However, with the injection of indocyanine green, you can assess that there's bright green coloration of the normal parenchyma, while the tumor itself, which was biopsy proven to be renal cell carcinoma, is actually dull and gray in appearance compared to the normal parenchyma. This is a tumor that has been taken out and bivalved under both white light and fluorescence mode, showing that there is bright green fluorescence on the normal margin compared to dull and limited fluorescence in the actual tumor itself. So a preliminary assessment of malignant versus benign tissue during partial nephrectomy, and also preliminary assessment of histology. What we know is that tumors, cysts, and areas of fat necrosis are hypofluorescent and easily distinguished from normal parenchyma, and this is a finding due to the differing expression of biliotranslocases, which is a carrier protein for ICG, present in normal proximal tubular cells. Previous studies with open partial nephrectomy have shown biliotranslocases expression to be significantly decreased in renal cortical tumors, correlating with decreased intraoperative near-infrared imaging. We know that biliotranslocases is also expressed in all oncocytomas, and therefore this is an oncocytoma lesion which has been bivalved, and you can see that there is actually isofluorescence of the normal parenchyma and the oncocytoma itself, so it can give you a preliminary assessment of histology as well. Again, this is additional tumors that have been bivalved, again showing the normal parenchyma, which is bright green in comparison to the tumor. Another tumor which is hypofluorescent compared to the normal parenchyma, which is hyperfluorescent and bright green. And again, another oncocytoma lesion showing isofluorescence throughout the lesion. I think this is where we are in terms of the future of fluorescence imaging. Enhanced specificity with fluorophores conjugated to specific targeting agents, where we can use it for real-time identification of tumor margins, certainly nerve identification in procedures such as radical prostatectomy and dissection of the neurovascular bundles, in pelvic malignancy cases, gynecological procedures for help in identification of the ureter and avoid iatrogenic injury, and certainly sentinel lymph node mapping in cases where the actual lymph nodes may be outside the standard dissection templates. So in conclusion, partial nephrectomy is a reference standard for T1 masses. It has oncological outcomes similar to radical nephrectomy, but is greatly underutilized. A pure laparoscopic partial nephrectomy has shorter convalescence but higher complications and warm ischemia time compared to open partial nephrectomy, and a robotically assisted laparoscopic partial nephrectomy may offer shorter warm ischemia time and should be considered the new standard approach for small renal masses in the T1 or T2 category. Certainly, I think fluorescence imaging is a platform for shift to image-guided surgery in the future, and we can expect it to have a greater role with all types of robotic cases in the future.